Dr. Conley, you're back with us for this section. Thank you so much for agreeing to be on 2 sessions. And then Dr. Subia is part of this panel as well from Sarah Cannon Research Institute. And then we have Dr. Brose, who is, we're working on getting into the panel shortly, but we'll start with the 2 of you. And Dr. Connolly, we met you this morning. Some people may not have been on in the earlier session, so maybe just a very, very brief introduction of who you are, then Dr. Subia, an introduction of who you are, and then we'll get into the discussion.
Sure. Hopefully you all can hear me well. I'm basically a medical oncologist at MD Anderson Cancer Center, and my role is I care for patients with sarcoma. And because of that, we have patients that have NTRK fusions. And so I've participated in the entrectinib study. I've been involved with quality or patient-reported outcome data with entrectinib, previously published a few years ago. But otherwise, patient care, happy to help.
Thank you. Dr. Subia.
Yeah, hi. I'm Vivek Subaya from Sarah Cannon Research Institute. I oversee the early phase research operations in the Sarah Cannon Cancer Network. Before moving to Sarah Cannon, I was a colleague of Dr. Conley and Dr. Hong, who spoke earlier at MD Anderson. I was at for 15 years. So I do precision medicine drug development. Have treated several patients with NTRK inhibitors, both entrectinib and larotrectinib, and I have personally seen the benefit of these drugs in patients with tough to treat cancers. Thank you so much for having me here.
Thank you both. And so we've heard a lot about, we heard some about current research, we've heard about other things that we're doing. And I have a question. I'm going to ask this question. I've just been told that Dr. Brose is now with us, so we'll let Dr. Brose, we'll let you introduce yourself. But before you do, I'll put the question on the table so people can be thinking about it. And that is, if you had one thing you wish that we knew right now about TRK inhibitor therapy, what would that be? So Dr. Brose, you can introduce yourself and answer the question, and then Dr. Connolly and Dr. Subaya, you can answer the question as well. Dr. Brose.
Okay, great. Thank you. I'm Marcia Brose. I'm currently working at Jefferson in the Northeast. I'm a cancer center director for both the Northeast Torresdale Division and also the Montgomery Cancer Center. So what would I say about TRK? So I've been doing personalized therapy. My PhD is in genetics. I've been studying cancer genetics my whole career. Love being part of the TRK program because, of course, it's so fulfilling to actually be able to target a gene. So now to get to your question, what do I wish I knew now? I've had many patients now who've been on TRK, and when they start to develop resistance, of course, we all want to know what's the best way and how to handle that. And it's not always clear that it's just a simple resistance mutation that can be fixed by maybe a better TRK inhibitor. Many times, actually, it might be a different pathway. So I think that what I'd like to know now is have a silver ball and try to understand how these people are going to evolve after TRK stops working, and whether or not, how we can combine either with other therapies more effectively, or even better if there was another genetic approach or a combination approach. So I think I'm probably not very original. Probably on everybody's mind is what do we do with resistance? So that's what I want.
It's very much front of mind, I think, both for physicians and for patients, is what do you do about resistance? And I think one of the challenges of working in a rare cancer is you just have to see a lot of people go through this to figure out what works, to do the studies, to do the work, and it's challenging. Anyway, Dr. Conley.
Yeah, I totally agree.
I think, did we lose Dr. Conley?
I think we lost your audio, Dr. Conley. Sorry.
No.
No. Technology is such a wonderful thing, isn't it? Ironically, I had some background noise going on, and I hit the mute button just when your voice cut out, and I thought, that's not what happened, I know. So,
Tim, I
okay.
can go ahead, but
Maybe
for the
Dr.
benefit
Subbiah,
of
you can
the
address it, and then we'll get Dr. Connolly next. Yes.
yeah, no, for the benefit of the audience, do you want to repeat the question so everyone knows where we are?
I'm sorry?
Do you want to repeat the question, Tim, because for the benefit of the audience?
Yes, so the question is, what is one thing you wish you knew about TRK inhibitor therapy?
Again, first off, thank you so much for having me over. And NTRK inhibitors, right? It was a game changer. Why was it a game changer to begin with? Because it's the first ever drug to be approved across all solid tumors in an age agnostic and tissue agnostic manner. Again, it's a game changer in the field of precision medicine. There was a drug, pembrolizumab, and immunotherapy approved before, but it had many indications. So the first ever drug to be approved in a histology independent manner was this watershed moment when we had larotrectinib approved. And then the second watershed moment was when entrectinib was also approved. Again, with these drugs, right, it's so rewarding to, find these alterations, right? It's like picking needles in a haystack. And, again, I wish we found these needles in haystacks at diagnosis so that patients can benefit right from the get-go. So with these drugs, even in the later lines of therapy, we see a high response rate. And again, a broad applicability across cancers. Again, many of these cancers driven by NTRK are rare cancers. And I wish, with NTRK inhibitors, I wish we tested more patients in the upfront setting at diagnosis so that these patients can benefit for a longer period of time with these drugs. Thank you so much.
Thank you. Dr. Connolly.
All right. Hi. Can you guys hear me now?
Yes. Yes.
Yeah. Sorry about that. I tried to get by using my Beats headphones, which I love, and I'm not endorsing them, but it didn't work this time. So just to not overlap entirely with what the others were saying is I would love to see the incorporation of ctDNA type testing to become more common. There have been some reports in the last 2 years or so with ctDNA data from the existing studies. Kind of like what Dr. Subbiah was saying, having, for instance, even ctDNA data at diagnosis along with what we know from the tumor is helpful for several reasons. So, these are blood tests that pick up DNA material, presumably from the tumor, right? And the idea is if we can quantify how much you have when you start and whether it correlates with treatment, maybe in the future, for instance, in the pediatric setting, we won't need as much imaging, right? Because we could simply query the blood and find out how well a patient's doing. Clearly, there's issues with that because not every cancer may exhibit the same sorts of qualities. And so it's probably best done in the context of the study. The issue is going to be, would it be something that, the wonderful sponsors out there would help, or would it have to be like a cooperative group type of approach? But that would be what I would add on. But clearly, I think the 2 points already made are, I think, the biggest and most important points.
Yeah, unfortunately,
Yeah,
I'll
sorry,
just
go
add
ahead.
on to that. I have the misfortune of being in one of those cancers that doesn't actually secrete DNA into the bloodstream. So we hundreds and hundreds of thyroid cancer cell-free DNA is sent out, and few return with the any DNA, much less the ability to do what they can do in lung cancer. So that, that's a wonderful thing to do if your tumor cooperates. But unfortunately, that's probably not going to be something we can do across all tumors.
Yeah, actually, there's a question that came earlier in the chat about, actually a couple of questions about exactly this issue, and that is, can you, the ctDNA is, and just for the larger group, and you who are smarter and much more into this, tell me if I'm getting this wrong. So tumors, a lot of tumors, not all tumors, will shed cells and DNA into the bloodstream. And so there's a whole field that's been growing now for 10 years or more about taking blood samples and looking for DNA from the tumors and analyzing if that is increasing. Does that mean the tumors are growing? What can you see and what can you learn from all of this? So when you say ctDNA, it's that circulating tumor DNA that's actually circulating in the bloodstreams. And people were asking, can you use that to monitor, to catch early signs of resistance? But it sounds like, Dr. Brose, that it depends. The answer is not in all tumor types. That's what
so
you're
let me
saying.
just fill in the background, and then I'll let my other colleagues talk a little bit more about their tumors and where it's great and where it's not so great. So the idea is not just that you can get DNA, but the reason you can pick up the DNA is that tumor is already associated with a mutation. So if that tumor doesn't have any mutations, you won't be able to tell anything at all from doing a blood sample, because the DNA will look just the same as all the rest of the DNA. So the reason you can pick it up is if you have, say, lung cancer that has an EGFR mutation, it's actually the mutation that you detect. And then the levels of that mutation can be tracked. That's my understanding. Unfortunately, with BRAF and things like that, we have not been as successful in my tumor types, which is primarily thyroid. But I think, the others here who've had much more experience in other cancers can talk about how it can be then more eloquently used in those situations that you brought up.
Oh, absolutely. I think that was a great question. So what is ctDNA? What we call it is liquid biopsy. So yes, circulating tumor DNA can be used for monitoring as a tool in cancer treatment broadly, including in the context of NTRK inhibitor therapy. Again, what is ctDNA? ctDNA technically refers to small fragments of DNA that are shed and released into the bloodstream by dying cancer cells. Right. So analyzing these shed ctDNA, the small fragment of DNA, allows us to peer into the cells and detect these genetic alterations specific to the tumor. So this provides a non-invasive method for monitoring progression of disease and assessing treatment response. Right now in 2023, again, we are much better in terms of the analysis of ctDNA than even a couple of years ago. I think 5 years from now, we will have better technology that will even pick up minute short fragments of DNA so that we can detect it in almost all patients. So again, as Dr. Bro said, today, the technology is such that, that it is able to pick up only in patients with specific cancers. And once they start shedding the DNA, once we pick up, we can monitor them, right, for changes in alterations in circulating DNA. Regular monitoring of ctDNA can offer definitely real-time information about the tumor's genetic landscape, and again allows the physicians and the healthcare team to make more informed decisions about the treatment strategies. Again, this approach is definitely valuable for assessing treatment response. Many times it also helps in diagnosis, treatment response, detecting minimal residual disease. If the drugs that we are using are impacting the disease, and most importantly, for future emergence of resistant mutations. Again, overall, the use of this liquid biopsy technology, the ctDNA as a monitoring tool, aligns with a broader trend in precision medicine, where treatments are tailored for specific genetic characteristics of the individual cancer. And we are going to see more and more and better technologies of liquid biopsy and ctDNA. So we still have hope that we have better technologies in place over the next 5 years.
So this is a very hopeful thing. So the answer is not right yet, but you can see where we'll get there. I have a different question, but I know Dr. Connolly, you wanted to speak to that, but so go ahead, and then I'm gonna push this a little further.
Oh, no. I was just going to say, to add to the complexity aside from tumors is, when the tumor is in a particular organ, is it going to be as prone to release DNA into the blood? For instance, liver versus lung versus other sites. So, just adds to the complexity. But yeah, I agree. I think over time we'll see more sensitive tools that will come out and help us answer some of these questions.
Well, I'm going to add to the complexity further. We know that in many cancers, cancers come around by mutations, and so they continue to mutate, and so as the cancer grows, you have what tumor heterogeneity. So this part of the tumor may look one way, and this part may look a different way because additional mutations have happened. Is that an issue in tract fusion cancer, or are they a little bit less heterogeneous, and if the heterogeneity is an issue, how do you have accurate understandings of what's happening in the body with increasingly small sample sizes? That's a lot to unpack. Sorry.
I'll take the start at it. I like getting let's do the easy part, and then like Dr. Subbiah and Dr. Conley could do the hard part because they're so smart. So the easy answer to that is the best we can do is if you have a patient who's been stable, say on a TRK inhibitor for a while, but then they develop a sudden nodule that's growing in a certain location, we can biopsy that location and see whether or not, and again, sequence it and look for, and ideally we would do a full panel, because sometimes we might find a point mutation in TRK that has caused it to be resistant to larotrectinib. But we also might just as easily find a mutation in another pathway altogether, maybe anything in the BRAF pathway or RAS or other things that could be the reason why they have resistance. And then just to make it more complex, then the question is, what do you do? So most of us, I think, if we have that situation and that small lesion or that lesion that's growing, unlike all the other lesions, is in a place where we can attack it and get it out by surgery or do radiation, we can sometimes irradiate that one spot, stop it from growing, and then we know that we can get another long period sometimes before another resistant spot opens up. So before you even have to have a drug that can attack it, sometimes you can go back to our old friends, radiation and surgery, because you're really often talking, it's not often that all the resistance comes in all of your spots at once. Often resistance comes in spots individually. So that's my first stab at it. And then, but I always, before I do anything, I try to get another round of genetics.
Okay.
Oh, absolutely. I think for the audience, what we know is, cancer, again, basic at the molecular level, is a malignant snowflake, right? So again, we are personalizing therapy with NTRK, but we can still personalize our precision medicine for patients in the future. So one of the main challenges with NTRK inhibitors, and also broad for all the tyrosine kinases, which are oral drugs that we use in cancer, is development of resistance. So all these, cancers, follow Darwin's theory of evolution. They want to survive from these drugs, from these best-in-class drugs, right? So they mutate. So specifically for NTRK, right, resistant to TRK inhibition for both larotrectinib and entrectinib, you can broadly divide them. Again, there are multiple mechanisms of resistance. You can broadly divide them into 3 categories. One is on-target resistance. The second one is off-target resistance. And the third one is unknown, right? Other mechanisms of resistance. So what is on-target? On-target resistance is when that gene, NTRK gene, there is a genetic mutation that involves a small amino acid substitution in that NTRK gene. That is what we call on-track resistance. So on-track resistance, again, technically physicians call it solvent front mutations, gatekeeper mutations of the NTRK gene. And that could be also an interesting substitution of that amino acid called the XDFG motif substitution. So that is number one on-target resistance mechanism that we see. So we can get these on-target resistance mechanisms, as Dr. Brose said, by biopsy or circulating cell-free DNA. The second mechanism of resistance is off-target. Again, I just say to my patients, it's like phone a friend, right? So the pathway is not wired with NTRK. The pathway calls another friend, and another pathway is active, like a MAP kinase pathway, like a BRAF or a KRAS or a MET amplification as an acquired resistance mechanism. Again, this is a wild card. Many times we don't know which pathway off target, right? Off target gets activated. So again, the key is, monitoring expectantly, doing a biopsy, getting a circulating cell-free DNA. The third mechanism of resistance is, again, most of the times when we do the sequencing, it's unknown, right? So it could either be histological transformation from one tumor type to another, or we don't know the mechanism of resistance. So again, these are the three broad types of resistance mechanisms that we see today with the current NTRK inhibitor therapies.
Thank you for that. So I want to make sure I want to move on from this this topic but I have to ask one more question. Sorry, but if Dr. Brose, the way you described it, and any of you can answer this, but the way you describe it, you may have a nodule that grows up or a new tumor site that grows up, and you biopsy, you do the genetics on it, and you see that, yes, there's a different kind of driver that's pushing that. Does that mean that when somebody has a new tumor pop up, or even a tumor that gets larger, when they're on TRK inhibition, that doesn't necessarily mean that they should be taken off of TRK inhibition, because it may be that TRK inhibitor is still working for other tumor sites or large portions of the tumor? Do we know that? Is that still a question to answer?
I don't think that's a question to answer. We know that. So we know that when patients have resistance in some areas, if we stop the larotrectinib, now all the other areas will start to grow. So that tells us that it's still being clinically active in those other areas. And that's part of why, if you can just control that area, even with a bit of very, very focused, cyberknife radiation or something, just to that one lesion, sometimes you can get years again before you have to deal with another resistance.
Okay. I mean, I just find that really encouraging. You think about if you're a person who has cancer and all of a sudden you feel some new spot or something, or you see a new spot, and then it's like, what do we do? Maybe the best thing is, we can. I mean, we don't know. Every patient's different. So thank you for that.
I tell my patient, and I tell my patient, it's like a whack-a-mole game, right?
Yes.
So when something pops up, we got to hit it. So again, we call ourselves targeted therapies, but ultimately targeted therapy, as Dr. Brose mentioned, is surgery. So if we can take a tumor out, ultimately, it can lead to long-term benefit in these patients.
So thank you for that. So we've already talked a little bit about, with liquid biopsy, and that 5 years from now, we may be much further along. We can kind of see that. What else might we know 5 years from now that we don't know now?
So I can probably take this question. So again, right now we again, 5 years before we didn't have these drugs, and now we have this drug, and 5 years ahead, hopefully we will have better drugs. One thing is, we will learn more about resistance mechanisms. Over time, we will learn about the novel mechanism of resistance and how we can, prevent those from happening. And two is the side effects of NTRK inhibitors, right? So we are now seeing cumulative side effects, because we have patients 3, 4, 5, 6 years into it right now, on trials or off trials. So we see a lot of side effects from these drugs, and how we are able to manage the side effects from these, side effects like weight gain, fatigue, skin changes, hepatic issues. So again, patients are getting older. They are getting sick with other issues like hypertension and diabetes, and we are seeing drug-drug interaction with those drugs and NTRK drugs. So again, that is we are seeing, and again, long term, we need to see regular medical monitoring to assess the effectiveness of treatment. And hopefully, the landscape of treatment is continually evolving. We will identify the mechanism of resistance, and new therapies may become available over time to go after those resistance mechanisms. And again, every NTRK fusion or every patient situation is unique, and treatment plans should be tailored for their specific diagnosis and specific location. And it's important for patients, especially with NTRK, to make sure that they are involved in groups like NTRKers, so that they are aware of the ongoing research that's ongoing.
Very good.
I think one other point that I would make at a slightly different level, and pertinent to what we discussed earlier in one of the earlier sessions, is that I hope that in the next 5 years we can have better follow-up data, in kids and young adults, adolescents, the AYA group, because as we discussed earlier, it's wonderful that we've got these great drugs, but what effect does it have on their bodies long term, right? In terms of their height, in terms of their ability to perform in school, especially when it could affect cognition. So I think that, and again, there's been quality of life papers published looking at sort of the immediate aspect of these drugs and what it does, but it'd be great to see more long-term safety data, especially in the younger folks, because they're the ones that are, potentially going to be living on with this, right? So what will it do for their bone health, endocrine function, cognitive abilities, educational backgrounds? Hopefully, either both Dr. Subbiah, myself, or others out there, hopefully we can get some studies published to hopefully provide some answers to this. Because while we're working on these better generation drugs, we need to make sure that we're, helping patients with the psychosocial aspect of their lives and just the aging part of their lives.
Yep. Thank you. Thank you very much. Dr. Brose, what will we know 5 years from now that we don't know now?
I'm not quite sure about that, but one thing that we will, one thing we I think we'll know is there are a lot of patients who've had complete responses. And, we don't really, that's a wonderful problem to have because, what do we do when they have a complete response? Do we stop? Do we start? Do we keep going? Do we keep going for 6 months and then stop? Which we might have done in the past with chemotherapy. That never really was something we had to worry about before because we had almost no complete responses. So this is a completely new question. And we do, there's a group of us who are sort of on a steering committee with Bayer that works on all of this data on a regular basis. And more we're finding out like up to 50% of some tumors have complete responses. And more we're learning when we can stop it. In a recent series, 7 patients who had complete responses actually stopped the therapy. And actually out of all 7 of them, and they've been on it like for 5 years or whatever. And this is important because it gets to Dr. Conley's point about if you're having toxicity, especially in children, like how long do they actually need to be on it? Sure. And we know of the 7 patients who were then discontinued to see how they would do, only 1 of them actually recurred, and then they responded right away to reintroducing the larotrectinib. So right now, that was a study that was published with 7 patients, but there's a database now that's following all of these children, and they're enrolled into kind of like a follow-up study where we can see how they do long term. So I would expect that by 5 years from now, we'll have better readouts on a larger number of patients and how they've done long term.
Well, that to me is really, really exciting. I think, to know how long to stay on a therapy is so difficult. I'm just remembering, and you guys have been at this for a long time too, but I remember a conversation I had probably 15 years ago with a PhD researcher at MD Anderson, who was in immunology, and she was saying then, almost anything we do to the immune system, about 3% of cancer patients will have their cancer go away, and we don't know which ones and why and what, but some people just do really well, and figuring out why and who is huge. Okay, so we have a few minutes left before we open up to a bigger Q&A, and we do have some questions to address broadly, and I'm hoping Amy will be able to co-facilitate that Q&A with me. But so this will be a fun question. If someone gave you $250,000 today to research any aspect of TRK fusion cancer. Now, that's not enough to do a clinical trial, right? But it's not nothing. So if you had $250,000 to look into one question that you would love to have answered, what would that be?
So again, if you see the waterfall plots, I want all our patients to have complete responses with NTRK fusions. And until we get 100% complete response, we are not ready. We cannot call that this is a victory. So, studying those patients who have a complete response and comparing those patients who did not have a complete response and seeing the underlying underpinnings of cancer and why these patients did not achieve a complete response. I think that would be my number one research question.
Thank you. Who wants to go next?
I think that I would probably be doing a lot of resistance testing. I would probably use that to be doing testing on every single patient at the time of progression. I mean, we're already starting to do that now. We might, be able to fund more of it if we actually had, regular funding, because some people get a little nervous about me spending that kind of money every single time they progress. But I think I would probably be doing that.
Thank you. Dr. Conley, you're last.
Yeah. I would say I think having a functional understanding of the resistance mechanisms is definitely extremely important to help those waterfall plots all go down. I think understanding perhaps combinations for patients that have progression that's not just solitary would be nice to see. In other words, what drugs could we add to NTRK that could potentially be useful? And it may come down to, it may matter what type of cancer you have, right? Or it may not, right? It could be that if we see the same sort of players causing secondary resistance, then maybe there will be specific types of medicines we can pair with. So I think looking at combination strategies in patients that develop, not oligometastasis, which would be, it depends on who you ask, but 5 or less lesions or lesions that are accessible, but in patients that have more widespread disease, or in patients that have bulky disease that develops that can't be easily treated by other means. I think that would be the only other thing I could add on, because Dr. Gross and Subaya, I think, hit the nail on the head.
Okay. Perfect. This is really great. What I'd like to do is have a more free flow. I mean, this has been a nice dialogue a little bit, but I'd like to have a little bit more of a free-flowing dialogue around some questions that we've received through the chat and a few other places. And I want to invite Dr. Lopez Rios to join us if you can, back on camera, and to be part of this conversation. We have. I feel like there's so much that we still want to know about this, but let me start with this. We know that we have a number of different approaches to cancer, right? We have immunotherapy, chemotherapy, targeted therapy, these different approaches. What do we know, if anything, about which approach to start first with which patient?
I'm completely biased on that one. I mean, I have, I have genetics obvious bias because of my research work, but I would say that I think that the responses that we're getting, if you look at, say, immunotherapy, you get people who definitely get long-term responses and they're fantastic, but they tend to often be a smaller percentage. And we also don't know, as we were talking about earlier, which patients those would be. But when we have a really good driver and a really, really good inhibitor, we do know that those patients will do really, really well. And they tend to do well in larger percentages, right? We are talking about, we're having like up to 50% in some tumor types having complete responses with targeted therapy. So then the next question then becomes like, how are they tolerated? If they're tolerated well, I probably would hit that first. Now, we don't really know much about the interaction, say, between immune modulators and targeted therapy. And we've done some work in the past where we say, we know that if we have them on a targeted therapy and the targeted therapy stops working, we continue the targeted therapy and add in immunotherapy, we can sometimes get another prolonged period of stabilization. So we're starting to understand maybe how they would come together. But, given what I know right off with just, I'm talking about like the immunotherapies like Keytruda and things like that, I think I would probably do genetics. And the other thing I'll say is, if you also ask a question between like these, there's a long time that we didn't understand, are you better off with a really selective inhibitor, or are you better off with multiple inhibitors? And the rationale for that is, historically, when we've given chemotherapy, there's really beautiful data that shows that hitting more than one pathway at a time was a much more effective way to kill cancer cells. That was actually a key paradigm of chemotherapy for years, and led to why we have so many different combinations, because we hit the mitosis pathway or the microtubules at the same time we're hitting the DNA. And we know that if we do that, there's a real synergistic result. Well, with the kinase inhibitors, there actually was recently a study, and of course it's not TRACK, but it's RET, where we actually compared in the first line setting a very selective inhibitor to inhibitors that were more multi-targeted and not so selective for the target. In this case, it was RET.
Mhm.
And we really showed that the selective one was far and away better. It actually was a New England Journal paper, was just released at ESMO. So why this was so big was that answers that question, right? We didn't even know that until just, really definitively recently. So with all of these different inhibitors, I think right now I hit genetics first, but there might be some really amazing ways to do immunotherapy with it. What I don't know is, and maybe Dr. Conley and Dr. Sabaya would know a lot more about this, how do we target with immune therapy? Other than saying that people have high microsatellite instability,
Yeah.
or, a couple of those markers, but those are not that selective. So I think that the beautiful thing about the genetics is we can be selective. We know that being selective really works. So I'll let my colleagues kind of build on that or answer all the questions that I don't know.
Anyone want to add to that or build it out anymore or challenge it?
Absolutely. I think the decisive assault that we can assault on cancer is in the first minute, first round, right? Early in the disease course, when the genomes are simple, right? At diagnosis, if we have genomics at diagnosis, and if we find these NTRK alterations at diagnosis, I think we can create a decisive assault on those patients. Usually the patients who are sent for clinical trials, and currently patients are in the relapse refractory setting. And it's a paradox to me that these drugs are even effective in these complex, tumor genomes post all lines of treatment. So I think the decisive assault that we can do better, as Dr. Brose mentioned, is in the first minute, first round at diagnosis. And one thing is, right now, if you think about cancer, it's like the story of 6 blind scientists and the elephant. We spoke about genomics and immunology, but you have microbiomics, you have metabolomics, you have proteomics, transcriptomics, and beyond. So we perform shallow medicine for the patient in front of us. I think we need to have a better comprehensive molecular portrait. Over the next decade, I think we'll have a better molecular portrait of every patient walking in the door. I think the AI technology is enabling us. And I think it can give us key hubs for us to target at what points during the continuum of care. And we can come up with regimens for every patient that walks in the door. And that's our hope as well.
Yeah, just to kind of make another point, I think, we also face these external pressures right now, right, where, research is, I think, a partnership right now between industry and academic centers, and how can we help our sponsors, for that matter, these companies, stay interested in ultra rare diseases like this, right? Because, it used to be about, let's get a positive trial and then maybe we get an approval, but now it's like there's more than that, right? If we get the approval, what happens after that point, and how can we keep that interest alive? And I think, of course, stressing how the prevalence of patients living with this disease is going to continue to increase, I think could be the way that we help companies out there, remain interested, right? In other words, okay, fine, there's not a lot of patients that get diagnosed per year, but the population of people living with it certainly will. And so that may be one of the avenues. But, getting to the point earlier about these really exquisite inhibitors versus these dirtier, multi-kinase inhibitors, I think I agree. Ideally, we want, based on the data, to have these pure inhibitors. I guess the challenge is going to be having companies maintain that interest so that we can have second or third line type of development. In my disease area, GIST is like the perfect example, but even then, GIST is still much more common than well, I guess maybe we could argue that point, but I think GIST is still a bit more common than this, but that's a disease that's also rare, that's been very dependent on a particular set of kinase mutations, and yet there have been 4 or 5 FDA approvals. And there's certainly a lot of studies on the way from multiple sponsors. So hopefully that type of scenario can continue to happen for patients that deal with rare diseases such as NTRK.
Thank you. Dr. Lopez Rios, anything to add to this? If not, I have a different question I can ask you. So, but
go ahead. Yeah, because I don't treat patients, so maybe it's better if I contribute to something along the testing or the identification of future prospects. Yeah, so go ahead.
That's exactly where I wanted to go next. And I don't know, this is a difficult question for anyone to answer, I think. We hear a lot about genetic testing and the importance of it for these kinds of therapeutic approaches. And yet we know that most cancer patients are not tested, or if they are tested, they're not tested for a full, robust panel of mutations and alterations. And even if they are tested, we hear, from patients, certainly many times they'll have the test, but the physician who's putting together the treatment plan, that treatment plan is not necessarily informed by the test results, either because they've already decided on a different course of treatment or because they don't understand the results completely. I'm curious, what can we do to have more people who are diagnosed with cancer tested in the robust way that they need to be, given the realities of cost and accessibility and things? But not only that, but be treated in a way that's reflecting the test results. And do you see this as part of your role in helping guide physicians to get to that point?
Yeah, absolutely. I think the key again was in one of the words that you used in at the bottom of the NTRKers agenda. It's education. I think we need to generate data, so we are all convinced that the first time a patient visits or sits down with treating physician, with the oncologist, he or she has the results from comprehensive genomic profiling, and nothing has started before you have all that information available. There is some very interesting data in advanced lung cancer, where it clearly shows, I think in a very elegant way, if treatment starts before that information is available, overall survival is 6 months maybe. But if you have comprehensive genomic profiling before the beginning of first-line therapy, overall survival is more than 22 years, more than 24 months. So retrospective data, single center, et cetera, but I think we need to be convinced that we need to be as fast and as comprehensive as possible. And again, I think the only way or the fastest way to bridge the gap is by educating everyone involved. I mean, all the way from patients, like we are doing now, with this exchange of opinions, all the way to taxpayers and other people in the space. So yeah, very important. I think now we have the drugs, we have the technology, we have the data, we are convinced. So we need to, how do you say that in English? We need to finish the puzzle.
I remember talking to, I love your passion about this, and thank you. I remember talking to 3 physicians who were involved in the clinical trials for the first checkpoint inhibitor for immunotherapy, and they talked to me at a big cancer meeting, ASCO. All of you will know what that is. Not all the patients necessarily will, and they said, we are seeing 2 groups of people in our waiting room. One group of people are living, and the other group of people are dying, and the difference is this drug. And we know that drug was not that. I mean, it's great. It was a great advancement, but still not huge. But I think we're in that same situation where we have the drugs, we have the knowledge, but we have an increasing gap in outcomes because of the people who have access to a treatment plan that is informed by that knowledge. And I'm sorry, I'm on a soapbox, and I'll get off of it and quit pontificating. Any other ideas about how we can close that gap from anyone else? Any other suggestions? If not, we'll move on to another topic. But yes, Dr. Subbiah.
My personal thing is genomics has to be a part of diagnosis, right? So unless genomics parts of diagnosis, right, we can never get that because all the algorithms by all the societies are confusing. And it's so busy, it's so tough for the practicing oncologist to essentially go through the guidelines, go through the payers, go through everything. So again, we are there, we are getting there, right? Genomics is not just for therapy, it's for diagnosis, it's for prognosis, not just for that patient. If it's germline, it's for the family members as well. So again, the only way we can get there is if we can do genomics, both somatic and germline, as a part of diagnosis for every patient with cancer.
I think I think what you said is really interesting to say that it's part of diagnosis, because saying a person has lung cancer in this day and time is not a diagnosis. You have to say this person has, an ALK-driven lung cancer or a ROS1 lung cancer. It's redefining what we mean by a diagnosis. Very interesting. And there any other comments on this before we move to the next question? Yes, Dr. Lopez. Oh, sorry. Dr. Bros, you go first, and then Dr. Lopez Rios will. You said you have your hand raised. So Dr. Bros.
I'm so bad about knowing how to raise my hand. So
no, it's quite all right. We're talking amongst ourselves here. It's okay.
So I'll just add one more level. I totally agree with Dr. Subbiah. It has to be just like automatic, the same way we do an H&E stain on every single pathology specimen. We should be running it through an NGS sequencer. And we should do it immediately so we get the RNA and the DNA. But what I would add now, since my last track fusion that I diagnosed was actually in a patient who had a resistance mechanism to another drug, I would say we now also need to do the same thing at the time of resistance. My happy world would be getting genetics at every step, because we don't always know. And I think what's going to start happening is we're going to start to see actually track fusions as resistant mechanisms to other pathways. So, Dr. Subbiah was saying how you call a friend, like when track stops working, it calls a friend and you get a resistant mutation in RAS. Well, I have a patient who had a mutation in RET. And then when they got a resistant mutation, it turned out they had found track. So I think that, we never ever talk about track as a resistant mutation, because we always assume that it was something, because all the ones we know about are ones where it's probably the initial insult. But now that we have all these other mechanisms to attack other cancers, we actually might also find that this is actually going to address the resistant mutations, might be a resistant mechanism in another cancer. So I would just add another level of that in a perfect world with lots of money and lots of RNA sequencers everywhere, that we would be doing that.
I want to just follow up here. So do we know, I know this is an N of 1, right? So it's not a huge amount of data yet, but do we know if this track fusion was a result of ongoing mutation in the tumor, or was it present from the beginning?
Yes, I'm saying it was definitely new.
Definitely new.
It evolved after 3 years of another inhibitor, and it was not present at the start. So Dr. Subbiah is laughing at me. So let's see what he has to say.
Oh, absolutely. I think that's not the N of 1. I have a couple of other patients as well with similar stories. One case, we published it, one patient with lung cancer, with red fusion positive lung cancer. I think we published it as a letter in Annals of Oncology. And patient had red fusion, great response, and developed NTRK3 as a fusion as a resistance mechanism. And we looked into the first tumor. It wasn't there, only RET was there. Second one had both NTRK and RET. So again, you can call this a zebra, you can call this another zebra, and the resistance mechanism, you can call it a zebra unicorn, right? So again, it's not N of 1. So again, for the next patient, we were ready. N of 3. So for the second patient, we customized therapy with an NTRK and a RET inhibitor. The challenge was getting access to both the drugs were challenging, because both the drugs, again, going through insurance is always challenging, right? How do we customize and provide access to these patients, right? That was challenging, but ultimately we got the drugs. Patient did benefit from that, and patient developed another mechanism of resistance. So it was the story of, you say Hercules and the 9-headed Hydra. Hercules cuts off one head, 2 pops up. Same thing, we hit RET, NTRK popped up, and we hit NTRK, now ALK popped up. And how do we go with 3 drugs? How do we go with 4 drugs and beyond? So that is the problem. It's like the story of Hercules and the 9-headed Hydra. We are facing in oncology. And the key is first is right now, I think in 2023, it will be good to get these cases aggregated and published as resistance mechanisms, and see what we can do in the future.
I think with this group we have here today, you could probably combine your data and have a nice little paper on this. Dr. Lopez, you had your hand raised earlier and I didn't call on you. So please make your comment, or either your original comment or how it may have changed since then.
Yes, no, and I just wanted to, to come back to the idea that I fully agree. We need to test all patients. A diagnosis reflex testing, I think, is the way to go. And of course, after progression, this should be incorporated in all clinical workflows. And just a brief example, we recently finished a study where we prospectively hypothesized that we could sign out a large NGS panel in 72 hours, in 3 working days, in advanced lung cancer and early stage lung cancer. And it worked because of robotics and improvement in coordination. So I think now it's really not a matter sometimes of money. I think it's a matter of better communication and better coordination in clinical teams. So I think it's there. We have the technology, and we can really do it.
I think that's really exciting news, and it's what we've been hoping for, right? A faster turnaround on these things. And the hardest thing for a person who's just been diagnosed with cancer, the hardest thing for them to do is nothing. It's like, you have something growing inside of you that could end your life, but we're not going to do anything about this for 3 weeks while we wait for test results. That's really, really a hard conversation. And you guys know this. So if it can be 2 days, 3 days, come back after the weekend, we'll have a plan. That could be huge. Dr. Connolly, I'm going to call on you for the next question. We're getting some questions through the chat, and I want to. We could talk about this for so long, and it's so interesting. But we had some questions about kind of what's coming down the pike in terms of other drugs that are currently in trials or in development and things like that. And I think in 2 ways. Number one, what is promising, what is interesting, what may be different about the new drugs that sets them apart from what is on the field right now. And is there any likelihood that if you do develop resistance to a current drug, that one of these new drugs might still be effective? That's a whole lot to unpack. But
yeah, I think the simplest way to summarize it would be selectivity. I think what you'll find in development right now are drugs that have been born from the ashes of all the prior medicines that are out there. So you're seeing more exquisite inhibitors that are not just pan-NTRK, but NTRK 1, 2, or 3 focused, right? As far as whether or not those will result in less secondary alterations or resistance mechanisms, I think we'll have yet to see. We could also find that there could be some really profound on-target side effects as well, right? And the amelioration of side effects that we don't want, right? Because there have been some really nice review articles out there trying to pin down how certain on-target side effects may be a consequence of, blocking TRK, B, or C, right? So when we get these very specific inhibitors, will that help to alleviate some of those issues while also having us worry about new? Again, the paradigm I draw from is mainly from diseases like GI stromal tumors, where we've had more specific inhibitors developed with these very unique side effects, because you're hitting a target that's not just found in the tumor, but also in certain tissues like nerve endings, right? Central and peripheral central nervous systems.
Yeah. Okay. Very helpful. Any other? No, thank you. That's very helpful. Any thoughts from anyone else on this topic? If not, we can move to the next question. All right, thank you. I actually would follow up a little bit on this. I have at least 2 other questions I want to try to get to, and we have about 6 minutes. So I want to follow up a little bit on this. We had a question from earlier in the day about just asking for some clarity about TRK 1, TRK 2, TRK 3. Do we know any? I mean, I think people hear these terms but don't really understand what does it matter what you have, what you don't have? Are some related to certain types of cancers and others related to other kinds of cancers? Do they have anything to say about outcomes or likelihood to respond? Is there anything you could, I don't know who wants to take this on. I don't know, maybe Dr. Brose, you're the geneticist here, but anybody, I would certainly welcome anybody to contribute to this.
I think that what we're finding is that, there are certain fusions that are very prevalent in some cancers, like ETV6 fusions are very prevalent in some of the sarcomas, for instance. So there are some fusion partners that are almost pathognomonic for a certain cancer. But then in cancers like lung cancer, and also to a lesser degree in thyroid cancer, it's very promiscuous. So you can have 1, 2, and 3, mostly 1 and 3, and you can have a whole ton of partners. So there's not really a straightforward answer. They can be basically partnering everywhere. And in those cases, sometimes so within a single cancer, you can have multiple different fusion partners. It may actually be more related to, for whatever reason, like in smoking, it might be related to the toxins that, of course, the tissues are exposed to. Maybe that's why there's so many more partners than we see in other cancers. I don't really know that we have a good idea of why. And what you're getting at with the question of, are some better than others? That's what we call a phenotype-genotype correlation, where the different genotypes, the different fusions would lead to a different cancer. And I've even, looked at some, done some research on this in other gene types. And the answer is too early to tell. We really don't have enough. We haven't seen enough of them, basically, to say that these people do better. But when Dr. Subbiah was saying, well, why do some people's cancer actually get cured completely versus not? Was it because maybe those were some of those cases? Maybe if we start to put them together as we get more and more numbers, maybe we'll decide that, oh, this one fusion is one of the ones we really do cure. And maybe we'll start to know that. I don't think we have enough data yet to say that, but there's a hope that maybe one day we would have that information.
Okay, thank you. And Dr. Lopez, I'm curious, you have talked passionately about testing and the importance of testing as well. So when you test, a typical patient comes through, do you just say, oh, they have tract fusion, or how far do you subdivide that? How far do you go with that test?
Well, I mean, we try to run upfront NGS. So when you identify a tract fusion, it's not only the fusion and the partner that's in the report, but also the whole molecular context, which is still, I think, as Marcia was saying, I think before, still not that well understood, but might be important. So not only that if it's in track 1, 2, or 3, but also the partner might play a role, and also the whole context in which the fusion is developing, as we have, I think, learned for other fusions, ALK fusions, for example, or even now maybe RET as well, fusions. So that's why we try to release a report that is as comprehensive as possible.
And is that level of detail actionable given our current knowledge? Does it change a treatment plan at this stage of the game?
Yes, I mean, I have a more open-minded way of signing out reports, maybe because I practice in Europe, and we tend to include in our reports as much information as possible, even if the evidence is not super high or and again, I think then we discuss all these patients in a clinical tumor board and a molecular tumor board. But we tend to include as much information as possible because the field is changing so much with so many clinical trials and so many combination therapies that we think is the right way to go.
Yeah, thank you. I think that's a very well, I remember having a conversation with the Cholangiocarcinoma Foundation here in the United States, and they were talking to a sponsor who was going to do a clinical trial with a targeted therapy, and the sponsor wanted to do a fish test to see if people had the specific mutation. And they said, we will never endorse a FISH test in cholangiocarcinoma because the tissue size is so small. You have so little access to tissue. We want to know everything about it, even if it's not actionable right now, even if we don't have drugs for this now, something may pop up that we find out that if you have this information, there's a path forward. We literally just have 2 or 3 minutes left, but I do want to get to one last thing. We've had a couple of questions that I'm going to cluster together around managing side effects. And I don't know if anybody has any insights on this, but one person was asking about using steroids to help mitigate pain, withdrawal syndrome pain, particularly if you have to go off treatment. Another person was asking about testosterone, if people have low testosterone that's associated with weight loss, weight gain, or weight. I need to make sure I've got this question right. About the yeah, it was using, if you have low testosterone, that compounded weight gain and fatigue side effects. So any comments about what we're learning or what we still need to learn about managing these side effects? And are those kinds of approaches things that people are exploring?
Well, I'll just briefly, regarding the testosterone question, I would say that's really best addressed with the treating clinician because, you know, since these fusions can occur in a multitude of different cancers, I think you want to be careful using medicines, hormones that could stimulate certain situations. So it's definitely, I think, a case-by-case situation. So hard to give a really specific answer about it in that context. But,
yeah.
you know, again, since some of these issues like dizziness, the withdrawal pain, or, you know, fatigue, or these neurocognitive issues seem to be, you know, somewhat specific to these inhibitors, you know, the way we manage them is hopefully going to evolve. But, you know, to my knowledge, problems such as withdrawal pain, it's difficult because there have been people that have used things like NSAIDs and such, steroids. I don't know that we've got a good handle on it yet. I don't know if Dr. Bros or Subaya have found better ways to manage those types of issues.
So again, you know, one of the main side effects that we see long term with TRK inhibition is a weight gain, right? So again, you know, more and more patients, you know, we need to first record the weight gain in patients. So we need to make sure that clearly there is documented weight gain in these patients, and make sure that we do a, you know, complete workup, right? Hyperlipidemia, diabetes, and all that. Mm-hmm. So again, as evidenced by many of the studies or case reports, so there are several drugs that have been used to manage weight gain from NTRK inhibitors. Like they use phentermine, topiramate, liraglutide, orlistat, etc. And right now, you know, we have an exciting class of drugs called GLP-1 receptor agonists that are FDA approved for weight loss, not just for diabetes, for weight loss as well. And like drugs like semaglutide or many GLP-1 receptor agonists. I think that you know, those will be, you know, interesting to see how they impact, you know, patients with NTRK related weight gain. So again, there was another drug approved this week. So we will see how patients are being managed with weight gain with these new drugs.
Mm-hmm.
Okay, very, very helpful.
And then, I mean, and the last thing I'll just say is sometimes just decreasing the dose. I mean, if you have a patient who has a full response, you know, it may be just going to half dose is all they need to maintain that response. So, you know, it's always our last, you know, last ditch effort to control an intolerable side effect. But dosage, I mean, their patients, especially with the dizziness, for instance, larotrectinib can cause patients to be quite dizzy. But if you decrease the dose to 3/4 or a half, they can do quite well, and their tumors often still respond.
Perfect. That's a great finishing note. Thank you so very much for this. We are at time, and the panel was fantastic. The Q&A was fantastic. I'll just say to everybody, I appreciate you sticking with us for a long slog through this patient summit, but really, really fascinating. I never thought when you looked at how long we would be doing this, I'd be thinking, I wish we had more time, because I would love to continue this conversation even further, because it's, to me, it's not only interesting, but really exciting and hopeful. A lot of messages for hope there. So thank you, everybody. Susan Espinosa from the NTRKers, I'm going to turn it over to you for last words, and then we'll be done.
Yes, thanks, Tim. Yeah, I want to thank our panels and speakers today. It's been very valuable to hear you and get the most up-to-date information on NTRK. So from a patient myself, I'm very thankful for everybody. Please follow us you can join our Facebook group on our website, ntrackers.org, also Twitter and YouTube. And please reach out if you want to volunteer. We're glad to have you in any capacity. And again, thank you for everybody for attending, and the patients and all the caregivers that are on here as well. And also want to thank again Bayer and Genentech for their support, because with their help, we were able to have this patient summit today. So I hope everyone enjoys the rest of their day or night or morning or wherever you are. And thanks again for joining.